So firstly, hello, my name is Kate. I'm Head of Partnerships at scan.com, and I will be working with Mr. Malik on this presentation and CPD event. About us, so just want you to go into a little bit about Scan. I know some of you that are joining today's event may already be using scan.com, and that's great. But for anybody new, I just want to kind of highlight a little bit about who we are and what we do. So scan.com is currently the largest UK diagnostics platform in the UK. We've got 250 sites nationwide covering all main modalities. So MRI, X-ray, CT, ultrasound, DEXA. And of course, within those main modalities, we've got a vast amount of other scans that we're able to provide. In terms of the kind of the supply that we have a complete mix between independent sites, and then we also have partnerships with the large hospital groups. So we have a great variation of sites available to your patients and also individuals that want to self-refer themselves. Just going on to a little bit about the mission. So scan.com's mission is to improve medical outcomes by speeding up the time to diagnoses. And we're wanting to do this by improving access to diagnostics for everyone. And we currently, in terms of our network, have a scanning site 20 miles from 95% of UK postcodes. So we've got a fantastic coverage, and we've got a brilliant collective group of suppliers which fit into people's budgets, their time. So whether they're doing the school run, busy at work, or just day-to-day life, we're able to provide them with a site that are able to take them on as quick as they need. Now, finally, before I hand on to the main event, Mr. Malik, I just want to go over a few housekeeping bits. So first, if you have any questions throughout this session, please add it into the chat. And we're going to be discussing this either after Mr. Malik's sessions, as it's kind of split up into a few, or we'll do it at the end. Let's just see how it flows. Also, this session is recorded, and we will share it with you after. And also we will provide certificates of attendance to this CPD event. So keep an eye on your inbox, and that will have instructions on how to get yours. Now, finally, I will hand over to Mr. Malik, who is a trauma and orthopaedic surgeon, and I will pass over to him to run his presentation.
So my name's Atif Malik. I'm a trauma and orthopedic surgeon. My specialist interest is in knee injuries and sports injuries in particular, but I do hip surgery as well. And the reason I kind of developed an interest in this field was I trained up in Manchester, and the guy that I was working for at the time was a surgeon for Man United. And it would be quite an interesting experience as a young junior doctor to come out of the clinic and find half the Man United first team waiting in the clinic room. And that's kind of where I developed my interest in sports injuries and in particular. My interest is in joint preservation surgery, partial knee replacements, total knee replacements, cartilage procedures, meniscus preservation surgery in particular. I'm a big believer in save the meniscus, as one of my presentations will be apparent. The key for me is always to get people back to doing things that they want to do, enjoying the sports that they want to participate in. And I've treated amateur, professional, and elite athletes in the past. I've done stints with various rugby teams, cricketers, footballers, MMA, golfers, tennis players, a bit of a variety of different sports. So in terms of the knee essentially, in its very simplest terms, is a hinge joint, and it is the largest joint in the body. The purpose of your knee is obviously to provide stability, provide forward propulsion, and to give a bit of minor twisting movements in the lower leg. but it is also a very commonly injured joint in people who are participating in sporting activities. Particularly sports that involve a lot of twisting, pivoting, tennis, golf, football, rugby, etc. And of course, direct trauma can also be a cause of knee as well. The most common knee injuries, which we see, and I'm sure you guys see on a daily basis, is soft tissue injury, sprain of the knee, muscles, ligaments, tendons, and that is often associated with swelling, pain, which is localized to the knee. Majority of these, as you know, within a few weeks, and are best treated with rest, ice, compression, elevation, or the heat regimen, movement, exercise, analgesic treatment. Anti-inflammatory medications, simple painkillers can help. And the worrying signs straight after an injury is when someone is unable to put weight on the leg. So one of the first questions that I ask someone who comes to see me in clinic is, what activity were you doing? And I always ask for a detailed description of the mechanism of injury, because that helps give you an idea and a clue as to what could have gone wrong and what the underlying issue is. Now, sometimes, especially with the professionals or the elite athletes, they can actually take their phone out and say, well, here's a video of my injury, which is always very, very helpful. The second question I ask people is, okay, so when you felt, did you fall to the ground? Were you able to get yourself up by yourself? And were you able to continue playing? Now, if someone has had a knee injury, fell to the ground, managed to get themselves up, and managed to complete the game, that's a very different story to someone that's had an injury, fallen to the ground, and was unable to get themselves up and had to be stretchered off. And it just gives you an indication of the severity of the injury that you're dealing with. The initial 24, 48 hours, always beneficial to try and keep the knee moving, to try and prevent stiffness and muscle weakness. Again, one thing that I see very commonly in the NHS in particular is patients coming to see me with a cricket pad splint, which for those of you that don't know, is a splint that essentially keeps your knee in extension. And again, people working with rehab will understand that even a short period of time, a couple of days, in that sort of splint can be very detrimental to the muscle weakness and muscle power. And often people come to see you with marked quadriceps muscle atrophy because they've been in a pad splint. This is particularly so in the NHS because often by the time people come to see you from A&E, seeing you in clinic, it could be a week, 2 weeks. And it's always really important to try and counteract that. So one of my kind of pet hates is to get people out of cricket pad splints, if they're safe to do so, of course, as soon as I possibly can, and start getting them moving. So the particular sporting activities that we've mentioned, but also running, cycling, kicking, jumping activities can lead to tendon inflammation. Certain occupations, for example, people that are kneeling as part of their job on a daily basis, joiners, plumbers, roofers can develop conditions like bursitis, which is where the bursa becomes inflamed. Now, these thankfully do respond pretty well to conservative measures, especially in the short term. And then in the longer term, it's about trying to find either activity modification or trying to find orthotics, braces, supports to try and prevent future instances of the same issue. occasionally, and especially in the summer months, especially at this time of year when people start going out into the garden, you can sometimes see bursae which become inflamed due to either cuts, insect bites, and a short course of intravenous or oral antibiotics to try to keep that inflammation down. Then going on to a bit more severe knee injuries. Now, knee injuries where you start to worry that something more serious is going on are where people start complaining of symptoms like mechanical symptoms, are clicking, locking, and that could either be true locking where they are fixed in a particular position and can't move in either direction, or pseudo locking, which is basically where the knee locks, but by either gentle manipulation or gentle movements, you can get the knee unlocked. And it's really important to try and differentiate what your patient is telling you, because for different people, locking means different things. So whenever I say to someone, does your knee lock? And they say, yes, 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 my knee absolutely locks. My next question always is, just describe to me what happens. And sometimes it's not actually locking that they describe, it's more stiffness, which is very different symptom. The next thing that is, I think, important to ask is stability. And I usually ask a very leading question, like, can you rely on your knee? Can you feel as if your knee is strong and it's not going to collapse from underneath? Because again, a lot of people don't understand when you say to someone, does your knee feel safe? They're not quite sure what that means. And it's really important to try and understand what your patient is telling. With instability issues, the things that are common is instability when changing directions, when going around corners, going up and down stairs or inclines. So again, it's really useful to ask a bit more once you've got that kind of leading question out of the way and you've understood what your patient is telling you, to try and then ask a bit more detail. You know, does it happen all of the time? Does it happen walking in a straight line? Does it only happen when you're changing directions, going up and down stairs? So the next thing I'm really asking myself is, do they have an underlying cartilage issue? And that could be a meniscal cartilage issue or an articular cartilage issue, or do they have more ligament issues? Have they sprained, torn their MCL? Have they sprained, torn ACL or PCL? And these type of injuries rarely settle without some form of intervention. So again, important to try and differentiate. And whenever you have these sort of symptoms, clicking, locking, pseudo-locking, instability, then I think it's important to try and consider getting prompt specialist advice. How can we diagnose an injury that we're suspecting, whether it's a soft tissue sprain, ligament, cartilage, meniscus, osteochondral fracture? And clearly, listening to your patient, doing a thorough and proper examination is really important. That adds a lot of information, and often you get a bit more information from that than anything else. And then using your diagnostic skills or diagnostic tools, rather, to get a bit more information and confirm what your suspicions are. And that could either be by way of plain x-rays or MRI scans, potentially even CT scans if you're thinking about fractures.
Great. Mr. Malik, we have done the poll and it comes out that meniscus is the topic of choice.
Okay, do you want me to finish this or go straight on to meniscus?
Of course, yeah.
So consequence, I'll try and go through this quickly then. So the consequence of knee injuries, knee injuries left untreated can lead to chronic damage and lead to wear and tear, degenerative arthritis, and particularly when we're thinking about fractures, osteochondral fractures, where the articular cartilage is damaged. And as you can understand, when these are not tackled or treated appropriately, because you've lost that articular cartilage, that can cause further problems down the line. So treatment, we've talked a bit about early specialist input is crucial in trying to prevent or slow further damage whilst trying to control the symptoms that your patient is complaining of. Rehabilitation, physiotherapy, braces, orthotics, and particularly with different types of injections to know which injection may work better in which situation. When you have not caught things in the appropriate time frame, or your patient hasn't come to see you in the appropriate time frame, then it is about trying to prolong the life of their own knee for as long as possible. And again, lots of strategies, injections, osteotomies, etc., which can help prevent that. But ultimately, then we are starting to think about operations. Now, initially, you might be able to consider keyhole operations where we would try and repair, reconstruct using the principles of tissue engineering. However, when things are a bit more advanced and are more severe, then we start thinking about knee replacement, and that could either be a partial knee replacement, such as the bottom picture, or a full knee replacement, such as the middle picture. The conclusion essentially is that early specialist input essential to try and prevent and catch knee injuries and prevent severe injuries leading to long-term damage. Conservative options are always the best way forward if they are appropriate, and that has to be as part of a team with physiotherapy, orthotics, etc., rehab team to try and work together to try and get the best possible outcome for your patient. And when all of that fails, then surgical options. But again, it is a part of a team where even with knee replacements or osteotomies or meniscal repairs, for example, you do need a rehab team to help support the patient in the post-operative period. Okay, so I gather that you guys wanted to talk more about meniscus surgery. So what I will do is give me a second and I will load the meniscus slide up. So we're going to talk a bit about the meniscus. And again, this is a very long talk. I know probably already over time, so I'll try and go through this quickly. Meniscus is the cushioning cartilage inside your knee. You have a medial meniscus and a lateral meniscus. Each of those menisci has an anterior horn, a body, and a posterior horn. The anatomy of the meniscus has the fibers are circumferential fibers, but also radial fibers, and the meniscus is usually made up of chondrocytes with these blood vessels. Can you see my mouse as well? Yep. Can you see the mouse moving?
Yeah. Yes.
So these are the blood vessels that come in, and as you can see from here, the blood vessels are in the peripheral part of the meniscus, not extending all the way over. So this part, the articular side of the meniscus, is usually avascular, whereas the peripheral side is where all the blood vessels are. The purpose of the meniscus is severalfold: low distribution, shock absorption, joint stability, proprioception, and joint lubrication. Now, this is a very simple diagram just to understand what it's doing in terms of low distribution. So you can see these triangular bits with the shaded areas are the menisci. This is your joint. Now, you can see that your surface area where the weight is being distributed is going through, because of these menisci, is in this form and this shape here. So you're getting a very broad base of your weight distribution. When you don't have a meniscus, such as on the right, that focus of your weight distribution is a lot more focused and central, and therefore this area has the potential to become more worn out and more damaged. Okay. The Menisci vary in terms of medial and lateral side in terms of what they do, both in extension and flexion. The meniscus injuries that I usually see are usually, I would say, younger patients, older patients. I know that's very broad, but younger patients are essentially patients with healthy menisci who've usually gone through a trauma and have a high rate of associated injuries, and that could be ACL, MCL, PCL, etc. The older patients are usually have a degenerative meniscus, which is basically where the meniscus becomes worn out. And generally, when they come to see you, they don't describe an injury or a trauma. They usually come and say the knee started to hurt and they start experiencing mechanical symptoms that we talked about previously, whereas the younger group of patients are the ones that usually describe a particular injury. So the way I often describe this in layman terms for my patients is I say to someone that if I'm leaning on, I don't know if you can see my elbow on the camera. So if I'm leaning on my suit all the time, my suit can get a bit of a hole here. And that is because that elbow is getting all of my weight distribution in that one particular area and the cloth wears out. So that is my degenerative meniscus. Whereas I could be passing a nail or something or fall, and the corner of my elbow suit could be ripped because of an injury. And that is a more healthy meniscus, which has had a trauma and has now torn because of the trauma that I've sustained. So, and again, when I say younger and older, I'm not talking about chronological age. I'm talking more about biological age. I've done meniscal repairs in 65-year-olds who are very active, no arthritis, and playing tennis. So, you know, it is a patient by patient assessment. So again, the younger patients, sport is usually the precipitating factor, and it's usually a twisting movement with the foot planted, often seen with MCL, ACL tears. And the older patients are usually rising from a squat. Majority can't recall any particular injury. The main things, as we talked about before: pain, instability, locking, and swelling. The pain and the location of the pain is very important because that does try and identify where the injury is, whether it's on the medial joint line, which may be indicative of a medial meniscus tear, or the lateral joint line, which may be indicative of a lateral joint, a lateral meniscal tear. Particular movements that we were talking about before. So what causes their instability, what causes their locking, is also important to understand. Often these patients come when they have a block to extension, and it's really important to examine the opposite knee, because, for example, someone has a bit of hyperextension of the opposite knee but actually can't hyperextend the knee that they've come to see you about. Even though they might have 0 degrees of extension, for them that is not normal because the other side hyperextends 5 degrees, 10 degrees. So that is a block, and that often happens when there is something trapped inside the joint, usually the meniscus or the ACL, which is stopping the full extension and actually causing a physical block. Swelling often happens 6 to 12 hours post-injury and can be quite severe, especially if the tear of the meniscus is in that kind of zone, the red zone, meaning the zone in the meniscus where the blood vessels are located. The differential diagnosis: meniscal tears, ligament tears, chondral injury. By chondral injury, I mean the articular surface is damaged, and either there's a articular cartilage tear or an osteochondral fracture, which basically means a small chip of the bone taking the articular cartilage and the bone just underneath that. Sometimes patellofemoral dislocations or subluxations can be confused for ACL or meniscal injuries, because patients often describe a pop in your knee, which to most clinicians feels like a dislocation or a subluxation. But remember, you can have more injuries than one, so all of these can coexist. We've talked about our effusion, and again, a proper examination is really important because it does give you lots of clues. The effusion, we've talked about the feeling and the tenderness is positive in about 75 to 85% of patients. We've talked about the blocks and the checking of the movement, special tests for ligaments, and again, different tests for ACL, different tests for PCL and MCL. The meniscal provocation test, whether you do an Apley's or a McMurray's, doesn't really make a huge amount of difference as long as you do it properly and well. Again, x-rays to look at degenerative joint disease, especially when you're considering that older patient where there may be a degenerative meniscal injury. But if people are having mechanical symptoms, always better to get an MRI scan. And the MRI scanners are usually pretty good. We've got a couple of pictures which we go through as well. But remember, accuracy of MRI scans is not 100%, so always keep that in mind as well. I'm going to ignore that for the time being because we don't have time. So the basic rules of looking at an MRI scan. Menisci usually come across as a triangular structure, which is usually solid and dark, and therefore on a T2 scan will come across as a dark black, dark gray type picture. Fluid on a T2 scan it shows up as white. So any water, for example, will show up as white. So if you can see on this MRI, this is a T2 scan, these black triangles are your menisci, and you can see on both sides, medial and lateral, okay? This is a sagittal, so side view, and again, those triangles are there as well, one there and one there. Fluid just at the back there, so indicative of a bit of fluid inside that knee. When you start getting something inside that black triangle, then that is where you start thinking about tears. So you can see on this scan, there is a white line through the black triangle, and that is indicative of complete tear. 1 second. And again, this is a vertical tear. This is a radial tear where the sharp triangle point is disrupted. Okay? You can see the sharp point there, but on this side, that sharp point is not present. When you have a bucket handle tear, a bucket handle basically means that the meniscus tears and part of the meniscus flips up and acts and blocks the knee, and that is often seen as a double PCL sign. So the PCL is this black ligament on the back here, and you can see these two black ligaments, and one of them is not a ligament, one of them is a meniscus that's got a bucket handle tear. The root of the meniscus can also tear, which is a lot more serious and a lot more involved. So it's something to be aware of. The meniscus fragment, which is torn, can flip, and all of these do need further management. I think the rest of them are probably, I'm not going to go through because I think we're already running out of time, but I don't know if people want to see a few quick pictures. So this is an ACL on the left. This is a degenerative meniscus on the right, just so that you can get a bit of a clue, and you can see a complex tear of the meniscus, and here it's been debrided. So that is stabilized. You can imagine these bits of loose meniscus when the knee is moving can get trapped. So it's trying to stop that mechanical block. The results of meniscus resections are, again, I'm not particularly a fan of this. So apologies if I'm not sounding very enthusiastic about this, because my personal view is that when you can repair the meniscus, you should. But as many of you will know, the meniscus was traditionally always resected, no matter what age range, and the results weren't too bad. But the problem has always been that they do lead to wear and tear symptoms and arthritis. And again, when someone has arthritis already, high BMI, the degree of excision of the meniscus, and the age, these are all negative predictors of a good outcome. I want to just very quickly talk about meniscal repair. So, not all tears are repairable. And we talked a bit about where the tear is and the blood supply. So blood supply is really important, because the tear, if I repair it, does need to heal. If I repair a part of the meniscus that doesn't have a blood supply, then that tear will not heal. And the sutures will dissolve over time, and the tear will come back. So that's not a good plan. But where you can repair, you should. What the various techniques for repairs, and again, the technology is advancing every few months. There does seem to be a new implant or a new device that promises to revitalize and revolutionize meniscal repairs. But my view is stability and trying to keep things simple. So I usually use two particular type of implants, which I think give me everything I need. And you can see meniscus, which is repaired and sutured here. It is a very technically demanding operation. These are some of the sutures that I mentioned. So this is one I particularly use, the fast fix, but I also use the fiber stitch from Arthrex. Again, very technically demanding. And again, you can imagine all of these structures, nerves, arteries, veins, which are in very close proximity, and you have to do everything you can to avoid putting your sutures in these regions. Rehab is obviously very different for a meniscal repair compared to a partial meniscectomy. Me personally, I keep people non-weight bearing for 6 weeks, no deep squats for 3 months, and not 90 for 6 weeks as well. But rehab protocols do vary. Meniscal repairs don't have 100% success rates. Success rates are about 65 to 85%, depending on where the tear is. Medial meniscal repairs have a higher failure rate compared to lateral meniscus repairs, and that is obviously due to the loading. All patients have different outcomes, and again, that may be down to a selection bias. I think I'm going to stop there, because I know I'm already very much over time, and I've probably got another 30 slides on this meniscal. So I'm very happy to take questions if anyone wants to ask.
Yes, we do have a few questions. People are either able to, well, actually, I'll put, anyone who's got any questions, please put them in the chat, and I'll read through some of them. But the first one that came through was, do you require IRMER, sorry for the pronunciation, certification for referrals?
Nope, absolutely not. Anyone can refer. Patients can even refer themselves.
Nice.
Never quite understood this concept of needing referrals to go and see a doctor. If you've got a problem, you should be able to have access to the right person at the right time without having to jump through hoops.
Thank you. And the next question is, what is the prognosis or durability for suturing?
So, as I said, meniscal repairs don't have a 100% success rate. The repairs are dependent on where the tear is, and that is both in terms of whether it's a medial meniscus, the lateral meniscus, but also the location in the meniscus. So, for example, if the tear is in that area where the blood vessels are located, that is perfect, because that has the highest success rate, because the blood vessels allow blood, nutrients, oxygen to get to the tear, and the success rates are much higher. Whereas if we're in a part of the meniscus which doesn't have a good blood supply. So what we call the white on white zone. So red blood, white, no blood. So the meniscus is, if we broadly split it up into thirds, the outer third is the red zone, the middle zone is the red and white, and then the inner zone is the white zone. So we often classify, you might hear surgeons talking about white on white zone or red on white zone or red on red zone, and that's because that's just giving a description of where the tear is in the location of the meniscus. So that is important, but also the configuration of the tear is important. So when you've got so we talked about the kind of broad types of tears: radial, longitudinal, bucket handle, cleavage, parrot beak. There's lots of different terminologies. Now you can have a complex tear, which is basically a horizontal tear, longitudinal tear, for example, all in one. Now they are a lot more challenging to deal with in terms of being able to suture. And I often, what I do is I draw a meniscus on a bit of tissue to show my patients. And I, once I've drawn my once I've drawn my meniscus, I then create a tear in the bit of tissue. And if it's a nice clean tear in the bit of tissue, then I say, I can suture this, as you can see, and it will come together quite nicely. But if that tear, and I kind of tear the tissue paper up into kind of a lot more pieces, and I say, if obviously this tissue paper is now meniscus and it's torn in lots of different places, clearly you can see that that is a lot more challenging to repair and may not even be possible to repair. We didn't talk about things like meniscal cysts, which can often develop when a meniscal tear has been there for a long time. And by the time you've cut away the meniscus cyst and decompressed it, there may not be enough tissue left to repair. But the default position should always be, in my opinion, repair where you can, and only consider a meniscectomy, or a partial meniscectomy rather, when there's no other option. Again, there's no hard and fast rules. For example, if I'm repairing a meniscus, a complex meniscus, where maybe in a 65-year-old I would have completed a partial meniscectomy because I didn't think that the repair had a very high success rate. If that same injury is in a 16-year-old, I really don't want to chop out a 16-year-old's meniscus, and therefore I will try a repair, even though I might not be very optimistic of the success, because worst case scenario, I go back inside, a keyhole operation. Knee arthroscopy is not a big procedure, and I have either an opportunity to fix it again. And again, there are slides in the presentation I was going to get, I didn't finish, which do talk about re-tears and re-repairs of re-tears, or I still have the option of taking that meniscus out at a later date, but at least I've given it a chance.
Great, thank you. And another question is, how vascular is articular cartilage relative to menisci, and how do the recovery rates from suturing compare?
So two very completely different things. So meniscal repairs are obviously soft tissue, but essentially neither has a very good blood supply. So this is the reason why when you damage your articular cartilage, and that could be either a long-term slow progressive damage, what we call osteoarthritis, where the articular cartilage is worn away over time, or an osteochondral fracture where the cartilage is damaged because of a particular incident. The reason they are both worrying is because they don't heal and they don't repair. Now, I have done a lot of research on stem cells, tissue engineering, because that is my kind of interest. And I believe in the future that is what's going to happen. But ultimately, I don't think that technology exists at the moment where we can take cartilage and replace it with artificial cartilage. Lots of times this has been looked at. AC, I don't know if people have had any experience in looking after patients where who've had cartilage transplantations. There seems to be a bit more of a focus on artificial cartilage techniques. So there is a lot of work being done, and I think the next 10, 15, 20 years will be really fantastic to watch what happens and what develops, because I think it will come where we potentially may not even need to do knee replacements. We could take somebody's knee and regrow all of the cartilage in their knee and give them a biological knee replacement, essentially. But unfortunately, we're not quite there yet.
Thank you. And we've got time for one last question, which is: can a tear repair without surgical? Can a tear repair without surgical intervention?
Yes and no. So the tears, again, depending on location, if it's in a very vascular area, then potentially. But you've got to remember that your knee has something called negative intra-articular pressure. So whenever you are moving your knee from flexion to extension, you're getting a negative pressure inside. And what that essentially does is it sucks any loose meniscus, loose cartilage into the knee joint. Now, sometimes patients have a tear which has been there for a long time and actually doesn't cause them any particular problems. And very commonly in degenerative meniscal tears, we don't think about keyhole operations because the management for degenerative meniscal tears is not keyhole operations and debridement of the meniscus, because it will just come back. And it's generally not very successful in terms of the outcomes. Most people find short to medium-term benefit, but we're talking 6 months, 9 months, 12 months, and they're back in the same position. Whereas the traumatic injuries, again, very small tear, potentially may just get into a position where it just doesn't move and it doesn't cause any mechanical symptoms. Whereas if it's a bigger tear or it is flapping. So what I always say to my patients, just to help them visualize what's going on, is I describe, we talked about the knee being a hinge joint. So it's like having a stone inside your door hinge. If you've got a stone inside your door hinge, it's not going to open properly, it's not going to close properly. And when it does open and close, it's going to potentially scratch the hinges, cause damage. And that is often what happens.
Brilliant. Thank you so much. That's all we have time for today. But Mr. Malik, that was a brilliant session. Thank you so much. And for everyone that joined, we will be sending over the full recording and also all the slides over to you on who attended. And obviously, if you have any further questions, please let us know and we can send them over.
Likewise, if anyone wants to contact me directly, very happy to for you guys to share my email address. I'm in so my London practice is based just out of Harley Street at the Harley Street Specialist Hospital. I'm very happy for someone who wants to come and meet, talk, go through options, send patients. I'm very happy to do that. My other private practice, Milton Keynes, so again, very happy for people in this locality to come and spend a day and potentially go through, spend a day looking at surgical options and seeing patients. Always happy to help.
Yeah, really appreciate your time, Mr. Malik. Very informative talk. Thank you to everyone that was joining. And yes, we will send over all information tomorrow.